Everyone, and welcome. Today, we are going to do a deep dive into diarrhea. Now, I know it might seem like a very basic topic, but trust me, understanding its core mechanisms is absolutely critical, not just for your clinical practice, but especially for acing your exams. So let's get right into it.
All right, so here is our game plan for today. We'll start with the absolute basics. Then we'll unpack the different types of chronic diarrhea. And we're going to focus on the two key mechanisms you'll see most often. The goal is that by the end of this session, you'll be able to tell them apart with complete confidence. So, let's begin. Okay, section 1, the basics. First things first, before we can understand what goes wrong, we need to be crystal clear on what we are even talking about. So from a proper clinical standpoint, what exactly is diarrhea? So this is the first key point you must remember. You see, in medicine, we always need objective definitions. Diarrhea isn't just a subjective feeling of having loose stools. No, it is a quantitative diagnosis, and the number you need to remember is more than 200 milliliters of water content in the stool over a 24-hour period. This is our clinical threshold. Now, you might be thinking, how practical is it to actually measure stool volume in a clinical setting? And you're right, it's not always easy. That's exactly where this simple but, believe me, very powerful tool comes in, the Bristol stool chart. What it does is give us a standardized way to classify stool consistency, which is a fantastic proxy for its water content. And as you can see, this chart shows us the entire spectrum of stool forms. Look here, types 1 and 2, they point towards constipation. Types 3 and 4 are considered normal and healthy. But our focus for today is on the other end of the scale. Yep, types 5, 6, and 7. These are all classified as diarrhea. Now, another very crucial classification is duration. How long has it been going on? If it's acute, less than 2 weeks, it's usually due to some self-limiting viral infection. Not too worrying. But when it persists for more than 4 weeks, that's when we call it chronic. And this, my friends, is a red flag. It tells us that there's likely a more complex underlying problem, which is exactly what we are going to investigate today. And that brings us perfectly to our main topic for the session, unpacking chronic diarrhea. See, now we're moving beyond just what it is, and we're getting into the why. And this is where the real clinical detective work begins. Think about it. When a patient comes to you with diarrhea that's been going on for over a month, we can't just give them something to treat the symptom, right? No, we have to figure out the root cause. We need to ask ourselves, what is the pathophysiology here? Is the problem osmotic? Is something pulling water into the gut? Or is it secretory? Is the gut itself actively pumping out water? Or could it be inflammatory? So this table here lays out those three main categories for us. You have osmotic, which is caused by malabsorption. Think of lactose intolerance. Then you have secretory, which can be caused by toxins or even tumors. And finally, inflammatory, which we see in bowel diseases like ulcerative colitis. Now, while all three are important, differentiating between osmotic and secretory is a very, very common clinical challenge, and it's an extremely high-yield topic for your exams. So that is going to be our primary focus. All right then, let's dive into our first major mechanism, osmotic diarrhea. And just like the name suggests, this is all about that basic principle of osmosis that you learned back in school, where water always follows the solutes. Now, a classic sign of osmotic diarrhea, especially when it's caused by fat malabsorption, is something called steatorrhea. The definition here describes it perfectly. We're talking about pale, bulky, fatty, malodorous, greasy stools. It's a very distinct picture, and when you see this clinically, a light bulb should go off in your head. You should immediately think malabsorption. That's the root cause here. Okay, let's walk through the pathophysiology step by step, because this is a really key concept. It's actually a very simple chain of events. So, step 1, something isn't absorbed. It could be fat, it could be lactose, you name it. This unabsorbed stuff just stays in the gut lumen. Step 2, it acts like a little sponge or a magnet, increasing the osmotic pull inside the gut. And what does water do? Well, step 3, basic physics tells us water will always move to equalize that concentration. So water is passively pulled from the body into the gut. And what's the result? Step 4, diarrhea. It's a purely osmotic physical process, nothing active about it. Okay, now let's completely switch gears and contrast that with our second type, secretory diarrhea. This has a totally different mechanism. Here, the problem isn't something that's unabsorbed. No, the problem is that the intestines themselves are actively, and I mean actively, secreting water.
So what's really fascinating here is the mechanism. In this case, you have toxins. The classic example is cholera, or maybe hormones from a tumor. These things are basically sending a signal to the intestinal cells, telling them to, well, to open the floodgates. The cells then actively start pumping out electrolytes and water into the gut. That's the key word here, active. This is an active cellular process. And that's exactly why the diarrhea doesn't stop, even if the patient is fasting. The pump is still on. So now we have our two main culprits, right? We have a passive process driven by osmosis, and we have an active process of secretion. The big question is, in a real patient, sitting in front of you, how do you tell them apart? This is where our clinical detective work really comes into play. Well, the answer lies in a few key differences, which are highlighted right here in this table from our notes. This is a really important table. So let's take this information and break it down into an even simpler view, just to make it super easy for you to remember. Okay, listen up, because these are the two most important, most high-yield features you absolutely need to know. First up, the response to fasting. Think about it. It's logical. In osmotic diarrhea, if you stop eating the thing you can't absorb, the diarrhea stops. It's that simple. But in secretory diarrhea, it just keeps going, regardless of food intake. And second, and this is a big one, is the stool osmotic gap. So how do we actually calculate this famous gap? Well, think of it like this. First, we measure the total amount of dissolved stuff in the stool water, that is, our measured osmolality. Then we calculate the stuff we expect to be there, which is mainly electrolytes like sodium and potassium. Now, if there's a big difference between the total stuff and the expected stuff, a high gap, what does that tell you? It tells you there is a lot of other unmeasured stuff in there. And what is that other stuff? Those are our unabsorbed solutes, and that points us directly to a diagnosis of osmotic diarrhea. And we can get even more clues. We can start to figure out the location of the problem. Is it in the small intestine or the large intestine? This table here shows some really key differences. For example, notice how steatorrhea is linked to the small intestine. Why? Because that's where most fat absorption happens. So signs of malabsorption often point to a small intestinal osmotic cause. On the other hand, signs of inflammation, like seeing blood or mucus in the stool, that usually points towards the large intestine. Okay, let's do a quick revision of the most important high-yield points from everything we've talked about. If you're preparing for your exams, this is the slide you really want to pay attention to. Maybe even take a screenshot. Okay, so pay close attention. Osmotic diarrhea, it's all about malabsorption. It stops with fasting, and it has a high stool osmotic gap. Got it? Now, secretory diarrhea, this is driven by active secretion. It persists during fasting, and it has a normal stool osmotic gap. Super important. Steatorrhea is the hallmark of malabsorption, so it points towards an osmotic cause. And finally, remember that small intestinal diarrhea is typically large volume and watery, while large intestinal is smaller volume, more frequent, and might have signs of inflammation. If you can just remember the points on this slide, I promise you, you will be able to solve many, many clinical questions. So to wrap everything up, let's end with a classic clinical puzzle. I want you to think about this. A patient with chronic diarrhea is put on a 48-hour fast, and their symptoms completely resolve. Now, based on everything we've just covered, what is the most likely underlying mechanism? And what would you expect their stool osmotic gap to be, high or normal? If you can answer that, then you have truly mastered the key concepts from today's discussion. Thank you for joining me.